We'll start out with a review of last week, the disease of addiction. Here at Serenity Lane, we view addiction and alcoholism as a chronic, progressive neurological disease that's potentially fatal. That we treat that disease and put it into remission, but we don't have a cure for that problem. And I like to think of it similar to Alzheimer's disease or to Parkinson's disease, where the disease can progress and if it's not controlled can be potentially fatal. We talked about what the definition of a disease is, and a disease is a problem where an organ has a dysfunction, it doesn't work properly, that leads to symptoms, which is what patients complain about, and then eventually develop signs which can be observed by outsiders, whether it's a doctor or a nurse or a family member. And that there's certain tests that we can do that'll give us clues to the diagnosis, and then we make a diagnosis based on something called the DSM-5 criteria, which is a book written by a bunch of psychiatrists, and there's 11 of these criteria. Those criteria break down into some big categories, the 4 C's, lack of control once I start, who knows what's going to happen. Compulsion, meaning if it's available, I'm going to use it. I have no resistance to using it. Craving, which is I'm obsessing about using even when I'm not using, or once I start using, I get thirstier and I want to drink more, or I get a desire to use more of my drug of choice. And then continued use despite consequences. You know, maybe you've had your second or third DUI and you continue to drink and drive is the most common example. Other criteria include tolerance, meaning it takes more and more of the substance to get the same effect, or physical withdrawal, meaning if I don't use the substance, I get sick. And then do I have medical problems related to my use, like cirrhosis of the liver or endocarditis from shooting up, or do I continue to behave in risky ways while I'm using, like drinking and driving, or drinking and climbing up on the roof to fix the television dish. And then we compared the disease to other diseases in that there's a genetic component, that we believe that at least 50% of addiction and alcoholism has a genetic predisposition, meaning that you're susceptible. And that if you're susceptible, there should be certain things in the environment that would trigger this particular problem. And the two things that seem to matter are the age of first use and something called an ACE score, adverse childhood experience. An adverse childhood experience would include things like I was physically abused or sexually abused, or I grew up in poverty, or I was a witness to violence, or my parents were divorced at a young age. And if you have a high ACE score, then it also puts you at higher risk of developing problems with drugs and alcohol. And then we talked about various biological models, mostly monkeys, where we hooked up monkeys to a machine that let them push a button and get a dose of cocaine to certain parts of their brain. And then that cocaine would then trigger a release of a chemical called dopamine. And dopamine makes us feel great. And using that monkey model, we figured out the pathway, the abnormality in the brain, which is the organ that's dysfunctional with alcoholics and addicts. That there seems to be at least a 50% genetic predisposition to developing abnormal behaviors around the use of drugs and alcohol, and that there's this cycle of addiction where we initially use and we get a very positive experience and we form a very positive memory, but then as our brain adjusts to exposure and we develop tolerance, we start to feel lousy when we don't use our drug of choice, and we start to have a negative feedback loop. And that if you want human beings to repeat a behavior, it's much stronger to make that negative feeling go away than it is to continue to repeat that positive feeling. And I talked about patients that were heroin addicts that would say, you know, I don't even enjoy getting high. I don't want to get high, but I wake up every day and I feel terrible, and I have to figure out how to find some heroin so that I'm not in withdrawal all day long, and that actually getting high annoys me. Or methamphetamine patients that will be able to not use for a week or two, but they feel so flat and so depressed that they say, I just want to use a little bit so I can feel normal again. And that, again, triggers this cycle of use, more use, craving, and back to unusual behaviors. And so we figured that cycle out using the monkeys. We talked about various neurotransmitters that are involved with the different drugs of abuse, whether it's alcohol or benzodiazepines or cocaine or methamphetamine. But then I want to start back with talking about how we treat addiction. And the federal government, through its wisdom, allows physicians to prescribe 5 medications that are FDA approved for the treatment of addiction and alcoholism. And the first one was approved in the 1970s called methadone. And methadone is an opiate. And an opiate is an opiate is an opiate, whether it's Percocet, which is oxycodone, or Vicodin, which is hydrocodone, or morphine, or heroin, or methadone, or fentanyl. They're all opiates. The only difference between all of those is how long they last and the potency per milligram of those particular chemicals. They all fit in the opiate receptor the same way. 2 parts of the opiate receptor is the kappa part of the receptor, which has to do with pain, and the mu part of the receptor, which has to do with feeling good, euphoria, and it also has to do with overdose, suppressing your breathing, and dying. So they all fit in the opiate receptor the same way. Methadone was approved by the federal government for people with opiate addiction back in the 1970s through very special clinics called methadone clinics. And how a methadone clinic works is you get up every day, you go down to the methadone clinic, and you get a dose of your liquid methadone so that you can't hide it or cheek it or take it away. And you get your dose, and you eliminate this negative feeling for the day, and you go about your day. And the reason that the federal government approved this was something called harm reduction. The government was interested in reducing harm to the community. Okay, they were not necessarily worried about the individual patient. And the harm to the community is trying to find that $100 to score some dope every day is criminal behavior. So they wanted to eliminate crime. They wanted to eliminate the revolving door of the legal system. And they also wanted to eliminate hepatitis and HIV, which were very expensive to take care of. So the government's interested in methadone clinics for harm reduction and cost reduction. The benefit to the patient is opiate heroin addicts overdose at approximately 10% per year, will overdose and die. If you're participating in a methadone clinic, that drops to about 1%. So the only benefit for harm reduction for the patient is lowering your risk of overdosing and dying. Only about 15% of patients will ever get off of methadone successfully. And the average course of treatment is 5 to 8 years, showing up every day at the methadone clinic. So you can imagine this is not wildly popular. Okay? Some patients refer to it as the liquid handcuffs. Okay? So the federal government in the year 2000 came up with another medication called buprenorphine, brand name Suboxone. Out on the street, they're called subs. And Suboxone is available by any physician who does some special training, and they can write a prescription for a week at a time, a month at a time, or up to 3 months at a time. And the buprenorphine's a little bit different opiate in that it's also a blocker. It's much stronger attachment to the receptor than the methadone or other opiates. But it also does not tickle the mu receptor very much. I used to say it all, but patients were in the back waving, oh, if I take enough of it, I can get high. So it doesn't tickle the mu receptor very much. It's virtually impossible to overdose on buprenorphine. Now, if you mix it with alcohol or Xanax or something, you can knock yourself off that way, but it has to be very deliberate and very large doses. So it's virtually impossible to overdose on the buprenorphine. It does fall under the harm reduction model. Again, the government is interested in lowering costs and protecting the public. We know that if you're on buprenorphine, the overdose rate is less. We don't know if it's as low as 1%. We don't have the research back on that yet. Patients like it because they can go to a private physician's office. They don't have to go to the methadone clinic, and they can be a little more flexible with their life. I prescribed buprenorphine in my private practice in Springfield for years, and I was disappointed in the results, in that patients eventually started chipping on weekends, which meant they'd do a little heroin on the weekends, go back to buprenorphine so they could go to work on Monday, and then eventually they'd start chipping more and more, and then the wheels would come off and they'd be in a full-blown relapse. So I did not feel like this was particularly successful at helping patients to recover from opiate addiction. So we don't know what percentage of people will be successful in the long run using buprenorphine. The state of Oregon is very adamant about promoting this. We started doing buprenorphine maintenance here at Serenity Lane in July, and we have a small percentage of our patients that are on maintenance for opiates on buprenorphine here. We do not do methadone. We don't necessarily believe in the harm reduction. We are interested in you as an individual patient. We want to help you to transition to an abstinence-based recovery. Now, we participate with medication-assisted treatment with buprenorphine as a useful tool to try to get you to abstinence eventually. Okay? Some patients, we can wean them pretty quickly in our hospital unit, and they do great. Some patients, especially ones that are IV users or have had multiple overdoses, we like to leave you on maintenance until your life is stable, meaning, good job, stable housing, stable relationships, and you're ready to wean off. But some patients will elect to stay on this long term, and that's okay as well. When patients are ready, we move towards abstinence. So those are the two drugs we use for opiate addictions. We also use naltrexone for opiate addiction, and naltrexone is a complete and total opiate blocker. It comes in and caps off this opiate receptor altogether. It's also a very strong bond to the opiate receptor. It will act like a bulldozer to all other opiates, including buprenorphine, and will push the opiates off the receptor and throw you into withdrawal if we give it to you too early. So we like to wait 10 days after your last dose of opiates, including the buprenorphine, before we would give you that blocker. And we give it as either a pill or an injection. We like the injection because you can't untake it. Okay? Once you have the injection, you're completely blocked from opiates. So even if you have a compulsive use, you find a couple Percocet in the car and you pop them in your mouth, you get nothing. You find a little baggie of heroin you hid behind the hot water tank that you forgot about, and you shoot up, you get nothing. It's a block. Okay? It's impossible to overdose while on naltrexone. So if you're using the medication appropriately, your overdose rate should go from that 10% to 1%. We know that it's not quite 1% because patients aren't always compliant with getting an injection in the buttocks once a month. Okay? So we like the naltrexone to try to offset this overdose if you choose to go to abstinence from opiates. And we like to do this to prevent overdose. The medication comes as a generic pill. Take it every day. It also comes as the injection. The brand name's Vivitrol that you take once a month. Side effects include it can aggravate elevated liver enzymes. So if you have liver trouble, we might hold off on it. It can also aggravate depression, although I've never seen that. The company says I should talk about it. It is a shot in the buttocks, so it's this gooey blob of medicine that you will feel back there, especially if you're skinny. If you're more padded, you might not feel it. And it kind of melts over 2 or 3 days. And it's very effective that way. It's expensive as an injection. Some insurances cover it pretty well. Some of them don't cover it very well at all. Most primary care doctors are now prescribing the pills. A lot of them will do the injection. Some of the pharmacies like Safeway will do the injections, or we'll do the injections here. Camprol is another medication. Oh, then we also use naltrexone for alcohol problems. Okay, We're not really sure how it works in alcoholics, but we do know that if you're taking it for alcohol use problems, the relapse rate is 25% less over a 6-month period of time. That if you do drink while you're on the naltrexone, that you'll have less days of heavy drinking, and that you have a higher chance of getting back into abstinence-based recovery while on the medication. We usually started out here at a half dose because it can make people a little bit nauseated. We like you to get it once a month if you're an alcoholic, in case you get what I call the premeditated relapse, where you get a resentment on Tuesday, you had a bad day of work, and you're like, forget it, I'm not going to take this medicine, I'm going to get drunk this weekend. So you stop taking the medicine. The shot gets you through that premeditated, resent-driven relapse. Because the medicine's there, you can't untake it. Make sense? So we like naltrexone. Patients tell me that when they've drank on it, it just kind of makes them miserable. They drink, they get drunk, they're miserable, they don't like how they feel, which is probably how it works, right? Blocks that sort of little bit of euphoria and craving that can occur with the first couple drinks. So Camprol is another medicine, a camprosate. It's very similar statistics to the naltrexone. It's a pill. It's 6 pills a day. They're about the size of this pen cap. So you can imagine it's not very popular. People tend not to stick with it, and it can be expensive. So I don't use it a lot unless people have had problems with the naltrexone. And the psychiatrist here, Dr. Breen, thinks it also helps with anxiety a little bit. So sometimes we'll use Camprol. And then Antabuse is a drug, disulfiram. It's been around a long time. I call it Pavlovian dog training for alcoholics. If you're taking disulfiram and you drink alcohol, you will get punished. You will be very sick. You will be throwing up, red in the face. And the idea there is, oh, well, I guess I shouldn't drink then. But I don't like it for that same reason of the premeditated relapse, where you get the resentment, I'm not going to take the medicine, I'm going to drink. And then occasionally I have patients that drink right through it. I'll just tough it out. And they just drink right through the throwing up and the red in the face, and they just keep going. So that's an example of good addictive thinking, and we'll come back to that. Okay. So these are the 5 that are FDA government approved. There's 2 other ones we talked about last week. Gabapentin is approved by the federal government for seizures and chronic nerve pain. We use it here for detox off of alcohol with high tolerance and alcohol and benzodiazepine combinations. It's not approved for that by the government, but there's lots of research, lots of use. And then Topamax is another seizure medication, not approved for drug and alcohol treatment, but we use it for alcohol and cocaine combination patients. For some reason, it seems to work pretty well for those folks. I use it occasionally when I have one of those kind of people in treatment. So these are the drugs we use. Sort of a quick rundown. Okay. Well, now that we're done talking about pharmaceutical, what else do we do to treat people here at Serenity Lane? How do we treat addiction? Well, 5 things. One is cognitive behavioral therapy. That's what we're doing right now. Okay? Breaks down into 2 activities. One is education. Hopefully you're getting some of that this morning. The second is teaching you about patterns of good addictive thinking, like, I'll just drink right through it. Or the last hurrah. Why did you eat a half a pound of gummy bears coming in the gate? Well, because I had them, right? The last hurrah phenomenon. Or why am I getting divorced for the 4th time and all of my ex-husbands are alcoholics? Well, maybe there's a pattern of thinking there that we can help you recognize and break before you do the same behavior again. Okay, so cognitive behavioral therapy and thinking. Does it work? Well, we know that if you do 6 months of cognitive behavioral therapy, that your relapse rate on alcohol is about 25% less. So it works almost as well as the naltrexone. The next thing we like to talk about is meditation. What? Turns out if you do 6 months of mindfulness meditation, organized programming, that your relapse rate goes down about 20%. And there's really, really good science here that if we put you in an MRI machine and inject you with nuclear sugar, and we show you really nice pictures of your family, and then show you pictures of horrible things like war, there's an area in the brain that lights up in the frontal lobe. And this part of the brain is the part that helps break this cycle of craving and addiction. If you do 6 months of mindfulness meditation, this area that lights up gets bigger. Really, really good science. So we have good statistics that say that it works. We have a good biological model with imaging that shows that it works. And I personally think this is the future of treatment and recovery. I have a friend that I play ice hockey with. He helped develop Farmville on the internet, the game. And he assures me that psychologists are the best programmers because they know everything there is to know about color, sound, getting human beings to repeat a behavior before they get frustrated and quit the game, and they're programming. I said, dude, get these folks to help me. And he said, oh yeah, they're working on it. And there are a few apps available on your phone. I've looked at some of them. I'm not terribly impressed, but I think they're helpful as far as trying to trigger this phenomenon. There's a group in the community now called Refuge Recovery. If you don't particularly like Alcoholics Anonymous, you can go to Refuge Recovery, where they start with 10 minutes of meditation and they end with 10 minutes of meditation, less religious talk. And they are probably tapping into this phenomenon with their meditation practice. So I think this is the future. I think if you're feeling really anxious and worked up here, instead of going to RHS and getting a pill for your anxiety, we're going to say, you know what, we're going to put you in the virtual reality room, put some goggles on, some music, some smells and colors, and you'll walk out going, yeah, I feel a lot better, okay? That's probably the future. Some treatment centers have those kind of facilities. We're working on it. Keep asking the man to put it in the budget. So we're working on it. So mindfulness meditation, other one's called facilitated group therapy. What's that called out in the community? Somebody? AA, right, Alcoholics Anonymous. Does it work? Somebody, only if you work it, right? Somebody usually yells that. Okay, so AA, does it work? Well, Alcoholics Anonymous has tracked their results all the way back to the first 100 people that were in the big book. And they say if you're in your first meeting of Alcoholics Anonymous, your chance of getting 1 year is what? Anybody know? Okay. They like to say it's 2/3 of people. What? There's a footnote. The footnote is of those that are really trying. Well, what the hell does that mean? Okay. That means they've been trying to quit. They're not there because the judge ordered them. They're not there because the wife is nagging them. They're really trying to quit, sincerely. And they've tried hospitals. They've been to jail. They're really trying to quit. And it used to be that you had to be sponsored into a meeting of Alcoholics Anonymous. Somebody went out from the meeting, interviewed you, and said, oh yeah, they're one of us. And they would sponsor you to come to the meeting at someone's house, which meant, A, you vouched that they were an alcoholic, and B, they weren't an asshole, that they weren't going to ruin the meeting, okay? So that was the original term, sponsor. If you look in the big book, the word's not there, okay? And we'll come back to that. So they like to say 2/3, and like, I don't know. I'm not sure I buy that. If you get 1 year, what are your chances of getting 5 years? Anybody know? 2/3. Pretty good research to support this, that if you can get a year of sobriety, your chances of getting 5 years is about 2/3. So if you do your middle school math, 2/3 times 2/3 is 4/9, which is a little less than half. Okay, like, okay, that's starting to sound acceptable. But if you're in the 1/3 that drinks, does that mean you go on to die a miserable alcoholic death? No, that means you go back to the front of the line, which is why their statistics look a little fudged, okay, because they are, all right? It turns out that if you're in your first meeting of Alcoholics Anonymous and you're really serious about quitting, your chances of getting 1 year is about 20 to 25%, okay? So here at Serenity Lane, we do facilitated group therapy. That's what your primary group is. You have a counselor that's there to help you get started in this process. Okay, so AA's been around for, 80 years now. It's been studied by all kinds of psychologists. What are the key factors to AA being successful? Anybody know? Number one, don't drink. That's a good one. What's that? Working the steps. That's number one. You got to do the steps. Okay, we put sponsor down here in number 4. Okay, we'll come back to that. You got to go to meetings. Got to show up. How many meetings you got to go to? 90 and 90s kind of gets thrown out there. Turns out you need to go to at least 2 a week or you get no benefit. Okay? And it turns out you get additional benefit up to going to 7 meetings a week or 1 every day. Going to more than 1 a day doesn't seem to add additional benefit. So 90 and 90 makes a lot of sense. And then finally, having a commitment. You're the person that makes coffee, you open the door, you clean up, you have some sort of commitment to the community, some job you do, okay? And then somebody yelled out sponsor. Well, what's the modern day sponsor's job? Get you to do the steps, not study the steps, not read the steps, but actually do the steps, okay? They're not your therapist, they're not your doctor, they might be your friend at the end, and if they're nice, they might be your cab driver if you need it, okay? But their job officially in Alcoholics Anonymous is to get you to do the steps. Inside of Alcoholics Anonymous, there's a group called the Step Do It group. Guess what they do? They do the steps. They claim a 90% success rate at getting 1 year. They probably pick the winners early, but if you do the steps, you can have a very high success rate. So facilitated group therapy. Al-Anon, the numbers are not as strong, but they're similar. Okay, so the next one is exercise. What happens when we exercise? Anybody? Endorphins, right. What are endorphins? They make you feel good. They are polypeptide neurotransmitters. A what? A polypeptide's a protein, okay? Your brain makes proteins when you exercise that attach to opiate receptors. Whoa, that's cool. My brain makes opiates. So can you get addicted to endorphins? Absolutely. Ever see somebody run till they break their leg? Marathon guys? Yeah, absolutely. So, when you exercise, you release endorphins. And I can tell you, if you're an opiate user, you use 30 milligrams of oxycodone or higher for 6 weeks or longer, you have shut off the endorphin system. You will not get euphoria from exercise. You will get, like, not much, okay? And people will say, well, if I'm coming off of opiates, should I continue to exercise if my endorphins aren't working? Absolutely. Lots of other benefits to exercise. Gets your adrenaline up, gets the weight off, lots of other chemicals involved. Does this come back? Yes, it takes anywhere from 6 to 12 weeks. So if you're a gym rat and you like to go work out, keep going and doing your workouts. Do some kind of activity that you enjoy. The other thing that happens with opiates, there's a little gland that hangs off the midbrain called the pituitary gland. And when you take opiates in similar doses that I just mentioned, you start to get low testosterone, gentlemen. Limp Willie, okay? Low libido, low sex drive, poor sexual performance. You'll go to the doctor, they'll check your T, you'll have low T. Do not go on testosterone replacement, because once you do that, you can end up with teeny tiny testicles and end up on external testosterone the rest of your life. So be patient. It can take 6 months to a year for the testosterone levels to come back to normal. And so, ladies, what does that look like? No menstrual periods. Hooray! As long as you know you're not pregnant, right? But when that starts to come back online, you're going to have irregular menstrual periods, maybe cramping, all that misery, right? Gentlemen, when your testosterone starts to come back online, you can go through puberty again, acne, nocturnal erections, nocturnal emissions, wet dreams, all that miserable stuff, right? So that can all happen again as the testosterone and hormones come back online. So one of the questions people always say is, well, if I'm on naltrexone, is that going to block me from getting my endorphins? And the answer is no. The opiate molecule is this big, complicated molecule, and it's blocked by the naltrexone, but the endorphin polypeptide is a sort of little molecule, and it can kind of sneak its way around the naltrexone and still attach to the opiate receptor. And the research all shows that patients can enjoy their endorphin rush after exercise while they're on naltrexone. So, and then finally, I put up here miscellaneous. And here we include acupuncture, chiropractic care, and massage. And here at Serenity Lane, these are sort of add-ons. Some insurances pay for it, some patients pay cash. Heath, our acupuncturist, tells me that 50% of people will come back for a second session that have never tried acupuncture. So at least 50% of you guys think acupuncture is helpful and will pay for it. So it's worth trying. Chiropractic care, we have a good chiropractor comes in. I think that's worth trying. Massage. I think these all work through the endorphin system in some degree, but they're all helpful for recovery. So if you haven't tried them, I would think about trying them. Okay. Now we start talking about some more interesting things. Well, why do people use substances in the first place? Well, typically, they want to feel different quickly, right? So if we're going to take your substances away, how do I feel differently quickly? If I don't like how I'm feeling because my midbrain is not firing properly, how do I feel different quickly? Well, there's some things you can do, right? You can eat. You can take a nap. You can go for a walk. If you have pets, pet the dog. We're working on a therapy dog here. Trying to put that in the budget. Yeah, everybody likes that idea. We put the garden in last year, 2 years ago. 2 years ago. Music. Well, how come we can't have music here? My taste in music might not be the same as your taste in music. You know, if I put my Juggalo Insane Clown Posse music on that I find relaxing, you might not find that very relaxing, right? Okay, or whatever. What was it, Mozart this morning coming in? Okay, so you can have sex. You can have sex with another person. Okay, nobody laughed at that. All right, I know you're all in treatment here, so residential. So exercise. My personal favorite is the sauna. I have a friend that has a sauna built on a deck, and he pipes in this spring water, and at the end of the deck is an old wooden hot tub with the spring water. So you go from hot to cold to hot to cold. And if you don't feel different after that, there's something really wrong with you. Okay. In a hot tub. Okay. So these are things that you can do to feel different quickly. Okay. You can change your visual stimulus. Very strong stimulator of our frontal lobe. So if you have a phone, which most of you do when you get out of here, put some nice pictures on there. Pictures of your family, your vacation, maybe some natural scenes. And when you're having a tough moment in the day, go take a phone break and look at your pictures. It will change how you feel. Go put some nice music on and look at your pictures. It'll change how you feel. Smells can be a very strong trigger. They can also be a very strong reminder of nice things. Okay, what do we smell everywhere here in Eugene? Marijuana, right? Walking down the street, you're smelling marijuana all the time. Maybe that's triggering you. Okay, so kind of be aware of that. You know, other visual triggers and stimulus. Since we're on that, what kind of movies do you watch? You gonna watch Scarface? Gonna watch Pulp Fiction? Shows him shooting up, right? Gonna watch what is it? Down and Out in Las Vegas, Leaving Las Vegas. What's that movie with Nicolas Cage? Yeah. So maybe be careful about what movies you watch. Try not to stimulate relapse. Okay. So these are some things to change how we feel quickly. Well, the reason we feel different is because of our midbrain isn't properly working. And whenever we experience what the Big Book calls the vicissitudes of life, or commonly known as stress, it can trigger our midbrain emotions and trigger the cycle of relapse. And so anything we can do to block stress from triggering our midbrain would be of benefit, right? How can we elevate that baseline resistance to stress? You know, when the car doesn't start, you're going to be late for work, you might get fired, then you're going to not be able to pay the mortgage, you're going to be on the street, and just that cycle of thinking that can happen with stress. So what can we do? Well, a lot of people like to put THC right here, or a glass of wine, right? End of the day, feeling a little stressed, okay? Well, we're taking that away, so what can we do? What can we... Yeah, you could do that. You could do some meditation. You could do some of those things we talked about. So this is called hedonic tone. What's your baseline mood? Are you happy-go-lucky, smiling? Or are you Mr. Grumpy-Gill, sourpuss, right? So how do you improve your hedonic tone? And personally, I played ice hockey last night. Played really well, didn't score. I'm kind of bummed out. But it makes me resistant to stress working today. I like to snowboard. I can drink a mocha. I get caffeine, chocolate, adrenaline, and endorphins in one downhill run. I'm allowed to do that. I like to ride motorcycles, dirt bikes, street bikes. See the pattern? I'm an adrenaline guy. That's what works for me, okay? You will not find me in a meeting knitting, okay? Lots of ladies go to AA meetings, they knit, they find that very relaxing and reassuring. That's not going to work for me. I know that, okay? I had a guy come up to me and say, hey, I like to go to my workshop and make puzzles and do all kinds of intricate woodworking. What do you think? I go, that's perfect, okay? That's going to work for him. That would not work for me. I would be so frustrated. So you got to ask yourself, what's going to increase my hedonic tone? Another word is the hedonic gerbil wheel. I like this one. This is getting over the belief that I'm supposed to feel good all the time. For some reason, Americans think that you should never have any pain or any stress or any discomfort. Okay? Well, life is tough. My favorite book, that's the first sentence. Life is tough. Okay? And so you have to get off of this constant pursuit of a good time all the time, that life shouldn't have difficult things in it. It is. You know, we all have parents. Most of them are going to pass away in our lifetime. You know, some of us are going to get fired from jobs. Some of us are going to have illnesses. Okay? Life is tough. So once you can accept that, you can get off that hedonic gerbil wheel. Okay? There are also this idea that there are preferred states of consciousness. What? Okay, so the easiest example of this is Michael Jordan was in the zone. Okay? Incredible athletic performance when he could get himself into a different state of consciousness. Some people like to be in the state of consciousness known as chill. I just like to be chill. I like to be relaxed. I like to be just hanging out, okay? That's your preferred state of consciousness. Nothing wrong with that. Some people like to be productive. I love going to work. I love being busy. I love being super productive. Salespeople, I love making the deal. You know, that's their preferred state of consciousness. So what's your preferred state of consciousness? You know, and how do I increase that in an acceptable way? Okay, so that's another thought. And then trying to define the word recovery a little bit for you. Okay, we talked a little bit about abstinence may or may not be part of your definition of recovery. Okay, If your drug of choice is alcohol, does that mean I can't ever smoke pot? Or if your drug of choice is heroin, does that mean I can't ever have a beer? Well, you're going to have to define that. What is your definition of recovery? Is it abstinence, complete abstinence? We're taking something away. What else are we going to put back in there, right? Most communities would say recovery includes fulfilling your roles in life. Am I a good husband? Am I a good wife? Am I a good father? Am I a good mother? Am I a good son or am I a good daughter? Okay? Maybe it's career oriented. I want to get my professional license back so I can fly airplanes again. Or maybe it's I want to finish education so that I can move up the ladder at work. Or maybe it's I want to participate in my community. You know, I've always wanted to be on this church committee, or I wanted to run for city council, or I want to be mayor. So maybe there's some community participation. And then most people just talk about personal growth. You know, I want to improve myself education-wise, maybe spiritually. You want to grow closer to your higher power. You want to spend more time in nature, or maybe you want to go back to whatever religious upbringing you had. So personal growth. Okay? So how are you going to define your own personal recovery? Okay. And then finally, I'd like to talk about spiritual experience. In the big book, there's an appendix about this. And my history on this might be a little bit off, but there was a gentleman named Ebby, hopeless, miserable alcoholic. And Ebby went to Dr. Silkworth in New York, said, I can't quit drinking. And Dr. Silkworth says, yeah, you're going to die a miserable alcoholic death. He goes, really, there's nothing else. He goes, well, there's this guy in Austria you can go see. And this guy's name was Carl Jung. Carl Jung was a neurologist, and he was a colleague of Sigmund Freud, who was also a neurologist, because they didn't have psychiatrists in the 1890s when these guys were practicing. They were trained as neurologists. And so he goes and sees Carl Jung, takes a boat, because they didn't have planes. He goes and sees him, has a few sessions. Carl Jung says, yeah, you're a miserable, hopeless alcoholic. You're going to die an alcoholic death. And Ebby says, really, you have nothing else for me? He goes, well, on rare occasion, I've seen people have what I can call only as a spiritual experience. And it's a sudden and dramatic change in their viewpoint of life and how they spend their time. And I cannot figure out how to trigger that in patients like you, but I've seen it happen. So Ebby goes back to New York. He meets Bill Wilson. And this concept of a spiritual experience gets introduced into the big book of Alcoholics Anonymous. And the easiest way for an average person to understand this is it's an overwhelming change in their philosophy of life. And there's a book in the big book referred to as The Variety of Religious Experience by a guy named William James. And it's sort of a textbook. If you're a nerd like me, you got to go read William James. And it's sort of a textbook, and he says there's 7 different types of spiritual experience. The most common is the painful educational variety. Also expensive. That's what you guys are experiencing. The painful educational variety. You've hit bottom, or you've had lots of misery, and you finally decide to seek some help. Dr. Bob has this experience in the hospital where the lights grow bright and it feels like there's wind in his hair and suddenly his whole life changes. That's rare. That sudden, dramatic experience. We had a patient earlier this year was literally struck by lightning, decided to come into treatment 2 weeks later. So maybe it was all that voltage, or maybe it was truly a spiritual experience, but he came to treatment. We had another patient this year that was attempting to commit suicide paddled a surfboard out into the ocean and claims that a whale flipped over him and his surfboard and pushed him towards shore. Whether it's true or not, it doesn't matter. It was a spiritual experience for him. He decided to come to treatment. Those are dramatic and sudden. Those are rare. Okay. Some people may have had a near-death experience, car accident, or maybe you're a cancer survivor. You were treated and you lived through it, and so your approach to life is very different. Your relationships are different. How you spend time is different. Maybe you've been to a third world country and toured a slum. You come back to the United States and you say, you know what, I don't have it so bad here. Those are spiritual experiences. I don't care what kind of spiritual experience you have. I just want you to have one. You're here. You're spending a lot of time with us and some money. Have a spiritual experience. Have a change in your outlook and perspective on life. Be open to it. Be open to it. That's what I have for you today. That's it. Any questions, anybody? Yes, you'd want to start the pills about the 30th day after your injection. Yep, that's a good way to go. Okay, great question. Yep. Repeat the question again. I didn't hear the first part. Been on testosterone, you mean? Yeah. If you've been on it, then no. I would go back to your doctor and talk to them. And if you've been opiate free for 6 months, then I would talk to them about what's the right way to come off the testosterone, if you'd want to try that. But yeah, if you've been on it a while, it may be you're stuck on it because the external testosterone has knocked off the ability of your body to make its own anymore. You just don't know. So yeah, but if it's being well managed and you got a good doctor, staying on it's not a bad option. So yeah, good question. Yeah. Yeah, that's a great question, and the answer is complicated. So the first part of the lecture last week, we talked about how methamphetamine and cocaine can drive down serotonin levels. And depending on how long and how much, and we don't know medically what that means, those can take weeks to months for those to come back. And sometimes we put people on what we call serotonin reuptake inhibitors, otherwise known as antidepressants, particularly one called Wellbutrin, which seems to alleviate some of that flatness that goes along with the serotonin levels being low. And, if it's intermittent meth use, it's not been daily for months, I would be patient. My experience here with patients is that typically it's about week 2, they really snap out of it, unless they've had this really long history with IV methamphetamine. Then I'm usually talking to them about being on Wellbutrin pretty early. So I don't know your particular story, but it's worth thinking about. And if you want to talk about it, you can make an appointment with the RHS secretary and sit down and talk about whether that's something you want to consider. But yeah, great question. Yeah. Right. Any other questions? Okay, I think we're done.
Thank you.
Yep.